Dr. Matt Fickie will be speaking about insurance coverage of genetic testing. Dr. Fickie is the Senior Medical Director of Highmark, Inc. For his full bio, please reference the attendee website. Please reference your screen for CEU accreditation and disclosure statements, as well as the CEU tab in the attendee website. Dr. Fickie, when you're ready, please take it away.
Thank you very much, Jacqueline. Sorry. Okay. Well, good afternoon. Good afternoon, everyone. Thank you for having me. If I can just say one goal for my session is to try to dissuade some of the dualism that I think most of us have in our minds about the faceless businessman in the insurance world and the Norman Rockwell-esque doctor who we certainly have in our minds as our own doctors, our own pediatricians through the years. The system is more complicated than that. And many things that each group does doesn't necessarily reflect upon the values and decisions that they might make individually. So I was not allowed to give one goal. I have to give 3 objectives, which of course I'm happy to do. So we're going to talk about common insurance terms and types of insurance. And if I go flying past some of those, please ask me about them at the end. We're going to talk about the different stakeholders, which today are going to be the payers, the laboratories, the doctors, and then the members / the patients, which aren't actually last in priorities, but it will frame their perspective better if we put them at the end. And finally, we're going to try to understand ways for a practitioner to improve their chances of approval of one of their requests. So try to understand insurance company behavior and try not to wind up looking like my kids or the Three Stooges. Okay, we in the insurance business are engaged in a constant cat and mouse game with laboratories and with providers. Laboratories will add unspecified codes for unspecified work. They will stack codes. They will change their tests and double the prices overnight. And providers who order these tests sometimes aren't qualified to order them. If the only type of lab in the world, genetics lab in the world right now is for pediatric rare diseases, and the only people who ordered them were clinical geneticists, I would be out of a job. But that's not at all how it works. There are principles behind what we payers attempt to do. No payer really wants to get in between a child with a medical condition or an adult with cancer. But what happens is good genetic testing gets swept up alongside bad genetic testing because we don't, and we meaning this entire stakeholder ecosystem, doesn't have enough CPT codes to properly represent the different types of tests. So to quickly define CPT code, that's a 5-digit, if you add HCPCS as alphanumeric, code that we use to describe tests or the work done in tests, depending on what you're talking about. And then payers, we hate getting defrauded. And everybody does, right? We've all had that moment where we've left a used car dealership or some other place saying, oh, how did that happen, right? And for payers, this is a constant battle. So starting on the payer front, the first thing that happens when someone asks for a test is it goes through claims. And this is an actual picture of Highmark's claim system. I did blot out a few of them for proprietary purposes, not that anyone would necessarily want to replicate a system that looks like this, right? And my real purpose for putting it up there is to say it's crazy convoluted. But essentially, the first thing you do is you verify who the person is and whether or not they have insurance through your company. The benefits also have to be verified, right? So does the member have the particular service covered? In the old days, there were genetic testing benefits. That's really gone now. You don't have to think about that. Then you verify who's responsible. Did this happen in a car accident? Did it happen in a hospital? Are we the primary insurer or the secondary insurer who, and we'll talk more about that as we go on. And finally, we have something called prepay edits, which will allow us to decide for any given CPT code, that 5-digit code that tells us what we're talking about in computer language. It can tell to approve automatically, to deny automatically, or to pen for physician and nursing review. So let me go into more detail on that because it's a crucial part of what I do and how we work in the insurance world. And if you understand it, you might understand some of your rejections better. So if I have declared a test investigational, I can deny it with no other information. If I say the test doesn't work, I don't care who it's going to be used on, it doesn't work. Okay. So the other thing we can do is we can look and see a little bit about who the member is in an automated way. So if you have a prior claim for whole genome sequencing and someone's asking me for it again, that's going to be denied. No human being is going to look at that unless there's a subsequent peer-to-peer and an appeal, which we'll talk about, of course, right now, actually. So medical review process varies by company, but the structure is basically the same. So step one is what we call an in-house review. So that's going to be done by Highmark, by Humana, by United, etc. Step two is an appeal. In between those two steps is a possibility of a peer-to-peer phone call, which is where the provider or doctor, or provider, I should say, provider who has ordered the test has the opportunity to speak to the reviewer who initially denied it. There's a super important caveat in this for all the providers who are listening, which is if you appeal, you immediately after you get the denial letter on that initial request, then you lose your peer-to-peer opportunity. Think about it as you went above my head before speaking to me. There's a peer-to-peer is standard, but is also considered an informal level of review. So please, if you think you do better on peer-to-peers, I'm going to tell you in a few minutes why I think you should do peer-to-peers. Don't forget that step. Step three, after the second step of appeal, is almost always an in-house appeal by the insurance company who covers the member. And step three could be an appeal to the same specialty reviewer or an independent review organization. So there are a whole lot of us geneticists who work in the field. So if you have a genetics denial from another company, you say, I want a geneticist to look at that. And if the insurer doesn't have a geneticist available, they have to go get one through one of these IROs. It should be noted that how requisite it is to do an IRO depends on the state and the health insurance plan. So New York State has a lot of these, other states do not, and even different employer groups will have different protocols for this. So it gets a little confusing, but in general, there's almost always going to be 3 levels of appeal available. When you're on the phone with someone, ask them what's available. That's my best tip for explaining it. Step 3 is the peer-to-peer. Excuse me, I have a cold. When discussing a case with a medical director, it's kind of like a lawyer. You can either pound your fist or you can argue the law. Same thing. You can either argue that every request had met the policy, and you can Google the medical policy because they all have to be publicly available. It's not to say that we all have the very best search engines on earth or anything like that, but you really can't find them. And if you can't argue the policy, argue the test is medically necessary, right? I know what your stupid policy says, but doggone it, this person needs this test. Both are actually completely legitimate and reasonable arguments, but you should probably pick one or the other before you get on the line. When it comes to the appeals, there is no formal difference between an initial review and an appeal. It doesn't usually, sometimes different docs who have more seniority are assigned to doing appeals, but there's not like the criteria change all of a sudden. Most medical directors are going to give appeal more scrutiny. Just human nature. Letters of medical necessity are a common question, and when it comes to genetics, they're probably one of the last vestiges where I see these often. And they can help. And they can help when they're not obviously written by the laboratory performing the tests. And they are not helpful where they're 10 pages long. No one's going to read that. And they're not helpful when they're antagonistic. So those are three things that you can do to help your letter of medical necessity be better. Have a clinician write it. You can copy and paste from the note. No one's really going to care, I think, too much about that. If you're making an argument that in this particular case, this patient needs this test because there's no panel that perfectly represents their symptoms, or there's a certain specific kind of testing, a variant that you can't find any other way. So one of the other things that people ask insurance companies, why is everything investigational experimental? Well, that's a very long question. We spend another hour on it. That's kind of what I like to talk about during a day. But let me give you a couple of ideas. Payers use different sources of information in our decision making that probably other people on this talk aren't thinking about. CMS is super important to us. Health technology assessments are as well. Hayes is a classic health technology assessment company. We really have to look at evidence-based guideline, not consensus guidelines. And I once had a reviewer say that to me and it made me mad. So let me just be more clear. If given a choice between a group that says we're consensus-based or evidence-based, we'll take the evidence-based, right? So endocrine and urology might both be competing for testosterone guidelines. We'll always choose the evidence-based. Consensus-based, the NCCN is consensus-based. That's okay. So I'm not trying to say that providers don't use evidence-based guidelines. You use it all day, every day. But just as a hint to decide which direction to go, go toward evidence-based guidelines. And finally, there's a cultural issue that is interesting, I think. Geneticists are almost always first adopters, and payers are fundamentally conservative groups. And so that's a cultural clash when it comes to implementing these types of things. Okay, done with talking about things from the healthcare payer's perspective. We're going to go on to the testing and talk about why the tests themselves can interfere with coverage and payment, etc. Okay. Excuse me. So these stock images of handsome doctors represent two different guys in two different locations, okay? Bill orders a craniosynostosis panel through a big lab east with United Healthcare, and it's approved. And Sam orders a nearly identical one using Big Lab West, also with United Healthcare, and it's denied. And I've been there, I've done it. It's crazy confusing. You don't know why. I can't always tell you why, but I can give you some hints, okay? Big Lab 1 may have just used 18 genes in that panel, and in which case they billed for 81402, the CPT code, which represents a small to medium-sized panel. And the company who is looking at this might have that might have approved it with or without looking at it. That's a pretty small panel. It's very reasonable for most things. But what if the other big lab, what if they use just 20 genes? Well, what might have happened is the same code, 81402, may have approved, but they may have added on the 81479, which is a molecular genetics unspecified code. And if you add that, and they may be doing that to represent the work used for the last two genes, or maybe they're using something else, maybe an MLPA for something they can't find with sequencing, etc. Anytime you build that code, someone's going to look at it, at most payers, because that code has historically been very used and abused. So because so it would not be improbable that we might say, well, we'll prove your panel, but I'm not sure what 81479 stands for in this particular circumstance. So here we have both the same codes approved, but what goes back to the doc is an approval and a denial, right? And so sometimes what you do is you don't have enough of the test paid for with the first code, and the lab is requiring that second code to be covered because it covers the whole cost of the testing, in which case they may say, we're not going to do the test for the price of an 81402, and that causes a denial. Let me go through a few other reasons, okay? Different plans, and I'm using UHC because it's the biggest payer in the country. I don't care who you put in there, may have different benefit structures. And one may have some stricter limits on genetic testing, may have a more narrow network. Generally, with out-of-network versus narrow network lab tests, and to define the words, in-network means that that provider has a contract with the payer, and thus it takes usually lower rates in exchange for consistent use of the test. And so in-network providers are much more quick to get approvals. Out-of-network providers require more scrutiny. Usually out-of-network testing that is available in-network is not denied by us, but it can lead to a higher copay, in which case, excuse me again, if you're using that laboratory who may have submitted this prior authorization may say you're going to have a higher copay, and the member tells the lab, no, I don't want to proceed with the testing. So be aware of all those different levels of complexity when you get a denial, right? You could have lack of clinical information or lousy notes coming from the provider's office. We'll get to that. And you may have a problem with the medical director's lack of genetics knowledge. It would be disingenuous for me to come here and tell you that every decision the medical director makes in insurance is accurate. That's why there are 2 and 3 different levels of appeal type work you can do. I've mentioned this lack of CPT codes, and I'll try to give it a little bit more detail without spending 30 minutes on it and boring everyone to death. But this is a huge problem for us. So, the way to think of it mathematically, it's the number of possible disease panels times the number of labs. And that's the number, and that's the size of the problem. So one solution for this is the American Medical Association invented PLA codes. And labs have to apply for those, and they identify specific tests. So if there are 10 labs in countries that do BRCA1 and BRCA2 testing, and yes, there's a code for BRCA1 and BRCA2 testing, there's like 20 of them. If you have your own BRCA1, BRCA2 testing, Fickie labs can go out and apply for a PLA code that helps identify it. If my strategy is to have really good testing, get a PLA code, and then go sell things in network to a bunch of different plans, that might be a really good strategy. That way, that Blue Cross Blue Shield of Connecticut can sign with me when my number, 0047U comes up, they know it's me. So the AMA likes these codes. I don't think they're thrilled with the way they're working entirely, and they're still trying to understand what's best to do with them. So they don't want these codes to be seen as an AMA seal of approval. They're strictly an identifier at this time. Just FYI. Sponsored testing. For years, labs made offers to doctors and to patients, send your sample to us. We cap that patient's out of pocket to $100, okay? I am the worst at this when I was practicing, so I'm not looking down on anyone. There is a problem. The problem is that if this is an out-of-network lab, there may be reasons why the payer doesn't want you to use that lab. And there are lots of good reasons why a payer may not want you to use that lab. One is the problem of fake labs, right? In 2018, that was the banner year when we had over $1 billion coming through fake labs. Some of these are vacant shops in strip malls, and they either steal the appropriate laboratory IDs, or they can make up their own, but they're fraudulent. At Highmark, we have found at least one of these. I think we found 2 of them. And we cover roughly 6.8 million people. That we processed 108 million claims last year. So finding a fraudulent lab is really hard, right? It's literally a needle in a haystack. It's not only fake labs. Sometimes we have information on quality. Sometimes we are paying them less for the exact same services at a network lab. And as part of our job as a steward and a fiduciary, we're trying to get a lower cost service. The downside to being on Zoom is that we can't hear everyone chuckling whenever I say these things about health insurance companies, and I understand that. But the truth is, we do this, and for instance, at least at Highmark, we work hard at making sure we have high quality labs, and make sure that we have enough of them that our members have good selection, good range. You're not going to have to go for anything that isn't what you want or need. Now, your topic number 3, we'll talk about where the doctors come into this, okay? So this is an important part. There are two, I alluded to it earlier. There are two very different types of providers out there, okay? When you're a geneticist and you do the type of clinical genetics training I did, and I assume some of the people in the audience did, we're taught that you're a better geneticist if you can recite the 15th and 16th genes responsible for Joubert syndrome. That makes you a good fellow, right? Laboratories are happy to accommodate this because reporting more genes on a panel doesn't really cost much more than just reporting a few genes, okay? But payers get very suspicious about this, and we start thinking, why are they doing a 56 gene panel for cancer when I can only count 25 cancer genes if I look it up, right? So that is a piece of the problem, okay? Is that we have geneticists and we have non-geneticists, right? Geneticists don't hold a monopoly on genetic testing anymore like we used to. I'll pause, and I know that we're on Zoom, so you can't do this collectively, which is a shame, but I would love to know who can identify all 3 of the doctors on this, and then we can all hang our heads in shame when I reveal who the one that no one knows is. We geneticists would love to have that 15 gene list, right? Because we know what genes we need, and we know what patients we need it for. Part of that is because most of us are trained in the era of old-fashioned sequencing where you couldn't just pick 75 genes at will. But salespeople also have a lot of influence over non-geneticists who are offering these types of testing as well. Examples are behavioral health providers who are offering pharmacogenomic testing when patients come. There's probably a role for pharmacogenomic testing in behavioral health, but we see it on patients' first visit. And I could love to explain why that's a bad thing. OBGYNs order gender testing as part of non-invasive prenatal testing. And, I think it's reasonable, again, to use the happy insurance language to not pay for that as part of a health insurance package, right? Neurologists, you can order repeat whole genome sequencing. I've seen it with my own 2 eyes. So these are some of the challenges that we have seeing all the genetic testing come through, not just what's coming from clinical geneticists, okay? And here it comes. One is a former Senate candidate in Pennsylvania. Number 2 is the lovely Dr. Phil. And number 3 is the one that's so embarrassing. That's Jonas Salk. And we should all know that one, right? Anyway. All right, doctors are also to blame for denials in the insurance world because sometimes they write lousy clinical notes. Here's a good example. I saw a blank today for depression follow-up. Now, if you skip down, you see that it says check pharmacogenomic testing under depression. That makes sense to me. Okay, this person has depression, it's still recalcitrant, and it's and they've got them on 2 meds. We would approve that Highmark. Here's another example where you're saying very similar things, except that, look at this. You put pharmacogenomics under lupus. And there's no pharmacogenomic tests that I'm aware of, though they're coming out, that will help us pick treatments for lupus, right? When we look at your clinic notes, they're very 2-dimensional. And I have been in a hurry many thousands of times having tried to write these notes. So I'm empathetic toward a hastily written clinic note, but this is exactly the type of subtle mistake that winds up with a denial. And I hope you can see that. Let me show you the most common reason why we get denials are the missing clinical notes. And again, I'm empathetic, but we can't do anything with this. We would be bad fiduciaries if we approve this, right? All right. Finally, let's talk about how members and patients have to interact with this insanely complex system here. So, excuse me, what's an underinsured situation? A high deductible plan sold to someone who can't pay the deductible, right? Most state Medicaid plans are underinsured because state Medicaid tend to have a much smaller pie to slice than, say, a private insurance company. Grandfathered plans, these are super rare, but these are weak plans that were in effect before Obamacare, and they're grandfathered in so that they can still be sold. And so they're pretty rare these days, but some of them make a comeback. Trump allowed the sale of short-term insurance products. So there's a few of them out there. But the most common situation is good insurance sold to someone who can't navigate it, which is most of the US population. And if I could wave a wand and fix any of these, that's the one I would fix. So there are workarounds for underinsured patients. High deductible plans, you wait until toward the end of the year, right, to ask for anything really expensive, because then all of your deductible is covered. As urgent as much genetic testing can feel, sometimes it could wait for 3 months. It's hard to think of. It's not the way that maybe we should always want to think of healthcare, but maybe if we did, it would be helpful in a few situations per year. Grandfathered plans or plans without genetic testing benefit, give it up. You're never going to get it. But the good news is those are extremely rare. And for people who have Medicaid, I preach to you to just adjust your expectation. They will not pay for whole genome sequencing in most states. You can't do it. Even if you argue that it's cheaper, you can't do it. If that medical director that day said, oh, sure, we'll do whole genome sequencing, they can't. It's not wired in the computer. The state panels have to approve it. It's crazy. So instead, take the panel and the microarray and go. And I know that's not the best care. It's not the optimal care, maybe, but we have to ration where our energy is going to be expended, right? Some of these things I can help you out with, some we just can't. But for well-insured patients, the best thing a doctor can do is to perform a peer-to-peer, okay? And it avoids having to put any onus on your patient, which can be, one, doctors can speak a language generally better than the patients, at least the genetics language, not the insurance language. And number two, patients are busy. They've got families and lives of their own, and they might be able to be as helpful 9 to 5 when you do this. You can take over and I didn't give a lot of tips on peer-to-peers, but the easy one is be nice. You can take over your patient's appeals rights. Your legal department will have that template. And if you do that, that would allow you, the doctor, to make that patient appeal. And those actually run in in parallel within insurance companies. So you have provider appeal rights and member appeals. And for instance, those member appeals might get you to a same specialty reviewer faster than going through provider appeals. Finally, know your region's primary insurers in-network labs. I know it's painful. I was lucky. I did almost all cancer genetics in my career, so I knew what each one wanted. They were preset tests. It wasn't rocket science. But if you know to send a myriad test to Cigna or Ambry to Aetna, your approval rates will be vastly higher. Your patients won't have as much out-of-pocket costs. The whole thing will be smoother, and you'll know the paperwork expectations up front too. That's very helpful. Federal programs. So Medicare has really extensive coverage for tests for cancer detection and for treatment. Their policies are much tighter for the hereditary cancers, but it also depends on exactly which laboratory you're using as to which test criteria click in. And that statement, which makes no sense to someone who doesn't understand Medicare, dovetails nicely with the fact it's really hard to find and to read Medicare genetic testing policies. But once you find them at cms.gov, you can click around and try to find the most beneficial laboratory policy that you can handle. The VA is a whole other world. They're well respected for their genomic research. They do approve some things. I am less knowledgeable about the VA, but they do have published policies as well. Secondary insurance I mentioned earlier. So this kicks in and covers costs when a primary insurance doesn't. So a classic example here is primary private insurance with Highmark, with the secondary insurance of Medicare Part A for a person who's on dialysis but is working. So Highmark primary, Medicare A as secondary. I know I'm low on time, so I'm skipping the other examples. The best way to manage secondary insurance is just to submit all of your copays to the secondary to help decrease your out-of-pocket costs. It's going to be very hard to try to argue the two different insurance companies' policies. Okay, the pitfalls of secondary insurance is that if the provider submits your secondary insurance before your primary, and that causes chaos. I'll leave it there. I can talk about the overinsured, but it's not that important, so I'll skip it. Patients, it's not fair. The genetic testing is not available equally. Lower income people have poor access. Lower income people can take up to 104 days from prior auth to sample collection for exome sequencing. That's awful. Rest assured there are people trying to fix it, but it's slow. So here's what I hope. I hope I've improved the status of insurance companies in your hearts, shown that good genetic testing does get swept up with bad genetic testing, or at least coding and billing, shown that there are these competing interests between these different parties, and explain that not everyone is acting in good faith all the time in this, and that's part of why it becomes so difficult. And with that, I will stop sharing, and I will turn the floor over to any questions that anyone might have. Thank you.
Well, thank you, Dr. Fickie. That was such a terrific presentation, and we have some really good questions that have come in. So I'll just start with those. So first one, when doing a peer-to-peer, how often is the provider able to speak to someone who is as knowledgeable as them? It can be so frustrating to speak with someone who has no understanding of genetics.
It's going to be rare. It's going to be rare. Here's how rare is it? So genetics is super complicated. Insurers often will vendor it out to a company like Evicor, right? Evicor has geneticists available. I used to be one of them, and my colleagues still are. So if you're going off to a vendor, which you have no way of knowing, and I'm sorry, there's no way to know that if you're a provider, you might actually be in good hands. If you're sticking with the company, I used to know one geneticist in Chicago. That's about it. I can't assuage the frustration. I can ask you to understand and act like they are just another family practitioner, and you're going to have to kind of start at the beginning and work your way up.
Great. Thank you. Next one, a big issue in rare disease is that these tests and diseases are, as the name indicates, rare, and so consensus guidelines are often not available or applicable. What's the best approach in that instance?
You're right. Yeah. So, okay. So the rare disease stuff is usually not where you have to worry about the guidelines so much. I was referring more to hereditary cancer, somatic testing for tumors and targeted meds. The FACMGG is doing some good research on this. They're putting together some good evidence-based stuff, and I do recommend citing those in anything that you propose.
Great. Okay, what resources would you recommend for families trying to navigate insurance for genetic testing on the family side of things, like getting a large bill in the mail after they thought and had done their homework that it was covered?
My next slide is resources and references, and I think I have something in there for you. And I know that one of the conference organizers does, because we had it back and forth. So we can post that someplace.
Perfect. How often are the contracts, policies, clinical criteria updated or revised by payers for genetic testing?
Yeah, thank you. That's a great question, because no one believes the answer. They must be reviewed every year. That's by NCQA, which is the accreditation group for insurance. If you vendor that out, again, to someone like Evicor, they do 2 reviews a year. And that's one of the reasons why a lot of companies will use them, because they get more updated information.
Okay. Regarding large panels for hereditary cancer, what's the downside of offering patients analysis of more genes than is indicated by the family history if cost to the insurance/patient is not different, as long as pretest education is provided?
So, okay, I think that's a fair question. Um, and I can speak to you as like the guy who helps with the genetic testing at his company, which would be to say, I agree with you, okay? And the way that we handle that is through our contracting. You know, but here's the downside from those people for the others who don't do it the same way. It is that if you don't contract with those labs and you say, I'll allow you 20 genes, then you can get a couple, 2 or 3 panel codes, and that you should be done, hopefully one. But if you allow someone to bill you 80 genes, you might be looking at a set of of CPT codes this long, and now you're paying a medical director for 45 minutes of work to try to figure out what you should or should not be reimbursing. It's not the optimal way to do business. I am blessed. Highmark is a not-for-profit, and we're not the one of the big five, but we're big enough that we can do that type of contracting work.
Great. Okay. What incentive do providers have to order responsibly when, quote, bigger is better is marketed to them? The report comes in, and at the end of the day, they are not on the hook for the bill when insurance denies testing that it's not medically necessary.
So I think that when providers do that, they're trying to do it in the best interest of their patient. Again, I will be clear, there's 2 different sets of providers, right? So when the geneticists do it, I tend to think that they're doing it because that's how we do it. We get 15 genes, we get it comprehensive, we tell people that's it. I think when the non-geneticists do it, there's a level of ignorance. Ignorance isn't the same as like as malfeasance, right? And I just want to make sure that that's clear. So there is no incentive. The only incentive is when the patients get mad, which is really like the last person, right? The last person we want to leave held with harm.
Great. Another question. I'm a genetic counselor and have been told by some insurance companies that I am not qualified to do a peer-to-peer because I'm not an MD, PA, or NP. This creates a challenge because MDs are often too busy to do these. Is there a way around this?
Depends on, I hate to say this is the worst answer ever, depends on the state. State law in Pennsylvania, it is only the ordering provider can do a peer-to-peer. We didn't know that for a long time, and we did peer-to-peers with anyone. Now, it happens that there is a certain level of education you get to where you can put that person on the phone with me, but it might not help you. Just keep that in mind. It's not with a genetic counselor, right? Genetic counselors can do great peer-to-peers. So unfortunately, it's going to depend on what state you're in.
Okay, what is being done to move toward more equitable care for under or uninsured patients, which disproportionately impacts minority populations who have less access to genetic testing?
Yeah, the best and most hopeful answer I can give you is that our SDOH work is happening. When I started Highmark 5 years ago, there were about 3 people in the company of 37,000 that knew what the initials stood for, and I can't go a day without it. I'll give you an example as it pertains to myself. We write medical policies for everything, and so if we're writing a medical policy for something, making this up, a gallbladder surgery. If the studies were not done equitably on people of different ethnic groups and races, we call that out. Or maybe a better example for this group is a polygenic risk score, right? It's going to be marketed to everyone. That needs to have lots of racial and ethnic diversity in the makeup of it. If you've made a test for rheumatoid arthritis, which is so distinctly a white female disease, we don't call that out, right? That just doesn't make any biological sense. So we're working on it. We're at the starting point.
Great. And I apologize, we have so many questions. We only have a couple minutes left. Another question, when we get denials from TRICARE, we are told there are no options for appeals or peer-to-peer. Is this true? I understand you don't work for TRICARE, but wondering your thoughts on how to handle these situations.
Well, I wish I could take that one offline. If anyone can get me an email address, I will follow up with that one. Yes.
Okay, perfect. Maybe time for one more. Can you speak to the role of genetic counselors in this process? I found them to be very effective in navigating, but at the same time, some insurers don't seem to recognize their expertise thoroughly. Thoroughly enjoyed this presentation.
That's terrific. So thank you. So what's the role of genetic counselors? I think, unfortunately, genetic counselors get a little bit sidelined. I mean, it wasn't 10 years ago when we were still fighting to get genetic counselors paid for office visits. And so you are stuck with this, who is the ordering provider, and that being kind of so unfortunately the genetic counselors might be stuck as the person who's helping organize getting the doctor on the phone with the insurance company between patients, or even, if you ask my opinion, schedule them. Or every time that there is a a person doesn't come in for their visit, just call a couple phone numbers, put them on speaker, and just wait to see if you get a peer-to-peer going. And so unfortunately, it might be that line. Letters of medical necessity have always been a genetic counselor thing as well. Can be helpful, as I stated. Really needs to come from you guys. Most of you have something already templated for whole exome sequencing, and I think that's helpful. I really do. I think it helps lay the groundwork intellectually. And if the medical director hasn't read it before they get on the phone with you, that's shame on them.
Perfect. Well, Dr. Fickie, thank you so much.